All right. Welcome everyone to our NephCure U webinar today on coping with prednisone. My name is Kristen Hood. I am NephCure's Director of Clinical Outreach, and I will be the moderator today for this educational webinar. I am so excited about today's webinar. First, there is probably not one patient in our rare disease kidney community that has not lived through the ups and downs of prednisone use. The side effects and how to cope with side effects have been some of the most common questions we at NephCure get from our patient community. Second, our very first NephCure Reading Club was started just a couple of months ago and was completely based on today's physician speaker, as well as the book she and her sister wrote together called Coping with Prednisone. It may work miracles, but how do you handle the side effects? So our reading club had almost 70 people in it, and we were engaged around the principles of this book. So thank you everyone for being here today. Before I introduce our speaker, I will let you know that I am going to ask the attendees to know that we will have a Q&A session at the end of Dr. Ingelfinger's presentation. Please submit your questions throughout the webinar using the Q&A function at the bottom of your Zoom toolbar. We will answer as many questions as we can at the very end. This webinar is being recorded and will be posted to NephCure's website as a patient resource. And finally, I'd like to recognize some of NephCure's sponsors who help make programs like this possible, such as Travere Therapeutics, formerly known as Retrophin, the Pfizer Foundation, and Goldfinch Bio. And now it is my privilege to introduce to you Dr. Julie Ingelfinger. Dr. Ingelfinger is a professor of pediatrics at Harvard Medical School, a senior consultant in pediatric nephrology at Mass General Hospital for Children in Boston, and is the deputy editor for the New England Journal of Medicine. She has been a consultant pediatric nephrologist and hypertension specialist and mentor in these areas for several decades. Her commitment to teaching in her professional career has been reflected by receiving many prestigious awards in nephrology and pediatrics, and also through her research. Her current research projects focus on the role of the intrarenal renin-angiotensin system in disease states and the role of maternal nutrition and gestational diabetes in renal development and perinatal programming. To that end, she has also written work for the general public, like you and me. One of these publications, Coping with Prednisone, is why we are here today. Coping with Prednisone is a book she wrote with her sister, a flutist, Eugenia Zuckerman, about what it is like taking glucocorticoids and how to manage life while on these medications. Published initially in 1997, it was revised in 2007 and has also been published in the UK. And with that, it is my honor to turn this webinar over to Dr. Julie Ingelfinger. Thank you so much for being here, Dr. Ingelfinger.
Thank you very much, Kristen, and thank you for that very generous introduction. What I'm going to do today is talk about some of the aspects of being on glucocorticoids, and I will also talk about why this book is still out there. And just in a moment, I think I will be able to start this. Okay, you heard about what I do for a living, and I have no related disclosures that are financial, but as a deputy editor at the New England Journal, that may confer an intellectual bias of sorts. So I'm going to talk about coping with prednisone. You can see the covers of the two editions here. And the reason that my sister is not here is that although she said to have a good time and she wished she could do it, she has some early cognitive decline, Alzheimer's, if you will, and she's written a prose poem book called Like Falling Through a Cloud, and spends most of her time on that and increasing awareness and hoping there'll be more research on that devastating disease, and hopes she can do that while she's still able to. So I'm going to start with the history of glucocorticoids in medicine, and you may know this, and of course I may be preaching to the choir for much of this talk because you've looked at the book and I'm sure have looked at handouts. So in 1930, it was found that taking an extract of adrenal glands and giving it to human beings with adrenal failure, something that would never have passed muster with today's institutional review boards, it was found that that actually counteracted human adrenal failure. Evidence in the labs of Kendall, Reichstein, found that there were actually many glucocorticoids. There's a whole family of them, and one is formed from another. And Philip Hench discovered cortisone, and for that he got a Nobel Prize. In 1940, it was recognized already that there were two categories of main action of glucocorticoids: salt and water retention, which when we're on prednisone, we experience to some extent, and sorry for the bings and bongs, some of them come onto my computer whether I like it or not, and glucocorticoids counteract inflammation. By almost 1950, cortisone was first used in a small trial. 9 patients with rheumatoid arthritis were given cortisone and they improved their symptoms. By the 1950s, ACTH had been used to treat nephrotic syndrome. And one thing I will say is that changed survival. Before there were antibiotics, only a third of children anyway, and a similar number of adults survived nephrotic syndrome long term. Once there was the presence of ACTH and then cortisone and other medications, it was a survival of 2/3. And by the time people learned how to use these medications, and there were ancillary medications, the survival is now over 98%. So it's a very different condition from what it was a century ago, or even 3/4 of a century ago. By the 1960s, though, the fact that being on cortisone, prednisone, other medications in the family led to side effects that were well known, and there were protocols to deal with them. So I don't know if you can see the small diagram of prednisone, because on my computer I'm seeing myself in a corner and Kristen and Kelly as well, so it's obscuring part of the slide.
Yes, we can see it.
Okay, great. So a patent for prednisone was filed in 1954 and approved in 1955, and it is a very commonly prescribed medication. Of the top 25 in 2017, where I could get the data, it was number 22, and I think it's similar now. The side effects, as I said, have been known for a long time. So why would you use it? Well, for one thing, prednisone acts pretty much everywhere, but in the kidney, what it does, represented by the little red pentagon that says GC for glucocorticoid, it binds to the glucocorticoid receptor in the cytosol of the cell, the part of the cell that is below the cell membrane, but not in the nucleus. And it changes its configuration somewhat. And then what it does is it moves into the nucleus, where it has a host of effects on transcribing other things, affecting other DNA genes for other entities, and it can act both to accelerate the transcription of these things or to repress them. And it's very helpful in treating inflammation. Within the kidney, it acts on multiple areas. Here is a glomerulus in this kidney, and the glomeruli, as you probably know, are out in the periphery of the kidney, and on average, there's 1 million of them per kidney. It acts in the glomerulus, where for nephrotic syndrome, the most important thing is that podocytes, which have a filtering membrane that's part of the tripartite membrane, can be affected by prednisone with a change in gene expression and a turning down of the leakiness that occurs in nephrotic syndrome. It's been the standard of care therapy for childhood nephrotic syndrome for many decades, and also for most forms of nephrotic syndrome in adulthood. And I have no way of knowing at this point which of you are perhaps parents of someone with childhood nephrotic syndrome or are patients yourselves. It has been the usual or standard of care treatment, as I said. It's still the typical #1 course medication, because when one looks at the adverse events and side effects of this compared to primary treatment of something else, it still is the most effective. Would your doctor ever avoid using it? Well, sometimes, and I'll get into that. And it is still used for second episodes of nephrotic syndrome, and then there's a wide variety in what people do. I wanted to mention upfront that there is a study in progress that might have an answer for how long do you have to do this. It is a study with prednisone for the first episode and then prednisone versus something else for the other. This is what is called a protocol study publication. It's called the intent study, and it's, in this case, going to look at mycophenolate versus prednisone. And what it will do is, in the first episode, everybody, and this is a study in children, gets prednisone. But after that, those who are screened after they've gone into remission, so it's not for someone who didn't go into remission, they are randomized, as with a random number table or a flip of a coin, either to get prednisone again, the control arm, what is always done, or to get an experimental intervention, a lower dose of prednisone and mycophenolate for 12 weeks, and then follow people for 2 years. I cannot tell you the outcome of this study, but it is exciting in that it will provide some information about whether prednisone, as compared to something else for a relapse, works. But what about other medications? When should you consider them? If you have frequent relapses and side effects that have potentially long-term effects, whether you're a child patient or an adult. In a child, there might be linear growth failure. There won't be that in adults. Is there steroid-induced diabetes? And are there other adverse events that are really troublesome? And we'll talk about some of those. Other health issues that have come up. You might need to be on much less prednisone or consider avoiding it if there are certain other things, like somebody is on prednisone for a relapse and gets chickenpox. And somebody who gets steroid-resistant nephrotic syndrome might be put on any courses of high-dose glucocorticoids in the form of prednisone and not do well. And if there have been unacceptable adverse events early or even before the first episode. So in thinking about, do you want to be on prednisone? Do you need to be on prednisone? One can think of the therapeutic actions. It's anti-inflammatory. It is immunosuppressive, which may be helpful in some forms of nephrotic syndrome. It also can suppress the vascular leak that occurs with florid nephrosis. It is an anti-allergy medication, and some evidence is present that part of nephrotic syndrome is related to allergy, and it may suppress pain. On the other hand, it has a host of side effects that I'll go through. And I would say at the outset of launching into these, please don't be frightened by them, since all of you have been looking into these things and have been active in NephCure. I'm sure you've seen them all. Many of these side effects you will never see, but I've listed most of them, and I'm sure you've seen them. So mood changes pretty much occur to some extent with everybody. Moodiness to major mood swings and more, and even psychosis sometimes. And if somebody becomes psychotic on glucocorticoids, that might be a reason to try something else as soon as possible. Difficulty concentrating may occur. This can affect schoolwork. It can affect work. Insomnia, people tell me, is a major problem, and in children can manifest in unusual things like refusing to go to bed, waking up. It can be quite disruptive in families. So how do you cope? And each time I'll talk about that. You can do preemptive counseling, which I think is very helpful, especially if you have clinicians who listen to you. Talk to family members about what's going to be happening, that somebody's going to be on glucocorticoids. Preemptively do this, and talk with teachers and the community you or your child are in. It's better to do that than try to keep it a secret. Consider therapy for mood changes, and this can usually be behavioral. Occasionally, medication may be needed. Then there are endocrine and metabolic side effects, which I'm sure you're familiar with. Glucocorticoids suppress the hypothalamic pituitary axis, and that can change adrenal reserve and can also change many different glandular systems. It also will lead to insulin resistance, both through hepatic and peripheral factors. Hyperglycemia, stimulated gluconeogenesis, that is making new sugar through activating some enzymes, can occur. And along with all of this, there can be dyslipidemia, which in plain English is high cholesterol and high adverse fats, such as low density lipoproteins. And possibly steroid diabetes can occur. How do you cope? One has to be monitored for these issues, and if they are present, it's really important to taper rather than stop prednisone and related medication suddenly, because that can lead to an adrenal crisis and cause a huge number of problems. And also, if one has to be on glucocorticoids for a long time, especially as with nephrotic syndrome, even before there were glucocorticoids, high cholesterol can occur. Do you need a statin? Should there be therapy? Is that reasonable? Especially when a patient is a child, the question is, should one do it? And I can say here, there is not a uniform opinion among pediatric nephrologists or internal medicine nephrologists, though more IM nephrologists would consider it. Weight gain and fat redistribution is very well known. Weight gain, fat redistribution, hunger and lack of satiety. And I have known patients who would get up at night and eat through a lot of the week's food. So how do you cope? Careful eating and talking about it preemptively is helpful. and talking to teachers and other caregivers, and also not saying, well, you're on glucocorticoids, you can't exercise. Low impact exercise is very helpful, and as is outlined in Coping with Prednisone, a relatively low calorie, nutritious, complex carbohydrate rather than fast food carbohydrates like candy bars and sugared drinks can be helpful in minimizing the weight gain. It can perhaps be helpful in minimizing the round face that occurs. There are other side effects, and I have a long list here. Cardiovascular ones are blood pressure usually goes up, and it can go up high enough to be in the hypertensive range, and that would need treatment. There have been studies suggesting that later cardiovascular disease is associated with prednisone dosage, such as atrial fibrillation and coronary artery disease. However, most of those studies are in people who received high-dose steroids in adult life. The way to cope, again, monitoring, discuss the change in sports to low-impact exercise if possible. And I must say, as I've been in pediatric nephrology a long time, I have patients whose whole life is focused on competitive sports, and we've discussed the benefit of continuing the sports or changing the sports or not doing sports, and I tend to be pretty liberal about letting people do most sports except for something like football, where you could be on the bottom of a pile of players. In some instances, if steroids are given long-term, bisphosphonate and other bone repair therapy can be considered. What about infectious side effects? These are concerning. Glucocorticoids suppress the immune system. You're more prone to get things, and people on prednisone are prone to certain viral infections such as varicella zoster and CMV, and may be prone to some bacterial infections, notoriously spontaneous peritonitis and cellulitis. How do you cope? Again, you need to monitor for exposure and symptoms, and it is worthwhile to let people know at your work if you're an adult, in your child's school, and other after-school activities that this child is on prednisone. We want to know if anybody comes down with something. Killed vaccines may certainly be received. In childhood nephrotic syndrome, for many years, people decided no vaccines at all should be given. It might cause a relapse, but that old saw has been given up. It's better to vaccinate somebody when off of glucocorticoids between episodes. And I should say, and you probably all know, that a certain number of patients may have a first episode of nephrotic syndrome and never have it again. But the majority of children with nephrotic syndrome do have more than one episode. And consider when and if prophylactic antiviral medication would be indicated. Certainly in people who have other conditions and receive, say, a kidney transplant, are put on antiviral prophylaxis, both because they may well be on glucocorticoids for quite a while, or if they're on a steroid-sparing regimen, also need to be monitored because this is immunosuppression. Hematologic side effects do occur, not that frequently, but they can cause a tendency to have blood clots in major vessels, such as deep venous thrombosis or a pulmonary embolus. I have seen some cases in children and adolescents, but so far not in someone who is an infrequent relapser. How do you cope? Monitoring again, and if this occurs, anticoagulation will be necessary. GI side effects are common. There's gastric irritation, heartburn with gastroesophageal reflux, ulcers can occur, abdominal pain may occur due to bowel wall edema, and that may be due to salt and water retention, but more often it is related to relapses or a first episode. Change in stool habits also may occur, and some people get pancreatitis very rarely or liver problems, but that's quite rare. How does one cope? Again, monitoring. Antacids or H2 antagonists and the like are often prescribed with high doses of glucocorticoids, and I tend to do that preemptively. Skin changes are very well known. Thinning of the skin leads to easy bruisability. There can be stretch marks, or their formal name striae, and there can be an increase in body hair and a change in scalp hair. It may become thinner, it may become thicker. Again, monitor and use sunscreen and avoid sunburn. And some people say if you get striae, to put vitamin E on it. I'm not sure whether it helps, but there's a lot of folklore that it does. And if the increased body hair is really problematic, using topical depilatories or shaving have been used, but it is reversible. Eye changes can occur, and this is the only one of these lists that I put a picture in because it shows a small posterior lenticular cataract. And these don't usually interfere with vision, but I don't really know what happens to them 20 to 40 years later, whether lens replacement therapy is needed. There also can be intraocular pressure that occurs. I mentioned cataracts, and one needs to monitor both for cataracts, which we can usually see in clinic, and one needs to see an eye doctor to look for intraocular pressure because there's medication to control that. What about serious adverse events and toxicity? Are there reasons to stop glucocorticoids even if they are quote unquote needed? Steroid diabetes means one should think about it or reduce the dose as quickly as is safe. If someone is severely Cushingoid, if someone has osteonecrosis of a bone, severe GI issues, and certain infections, and if someone is, as a child, stops growing completely for a prolonged period of time. Parenthetically, I'll say that as pediatricians, we usually look at height growth over a year, but if someone has really not been growing, it's worth thinking about, is there something to add to try to induce a very long-term remission? But these are all relative reasons, and every single patient, every person is an individual case, and so this needs to be discussed. So what do you do when you want to tell your doctor you don't want to be on this stuff anymore and you don't want to start it? Sometimes it's going to be at the first episode of nephrotic syndrome, a wishful thinking request not to start this, because I told you at the outset what the fatality rate was before there were steroids, and there is not an individual medication that can be given alone that induces a first remission. With maybe biochemical nephrotic syndrome, that is no symptoms, proteinuria, no swelling. Some people have tried an elimination diet. Some 40 years ago, the late Raleigh McIntosh thought that nephrotic syndrome might be due in some people to milk allergy. And there are some patients who responded, but there's also occasional spontaneous remission. Ultimately, before there were glucocorticoids, some children did have a spontaneous remission. or had a remission after they got a severe illness such as measles. Probably in the measles instance, it was because it was a shock to the system, and ACTH was secreted from the hypothalamus and caused endogenous steroids like cortisone to be produced, and essentially treated the condition that way. So discuss your reasoning if you want to stop glucocorticoids or not start them. Ask and then listen to what the consequences are likely to be for you. Ask about alternatives and ask about new research. Is there something new that has been studied that will be out soon? One thing I will say is that having written the first edition of this book with my sister 23 years ago in 1997, I thought by now maybe there would be something and nobody would need this book, but that has not been the case. I thought maybe there's going to be a wonderful glucocorticoid that everybody turns to and just focuses on the inflammation in the kidney, and there's nothing else that happens. And deflazacort, which you can't really get in the US, had some of those findings, but it has not caught on. So if the decision is that you are stopping glucocorticoids and trying something else entirely, again, I will say cold turkey stopping is a huge risk. It really has to be tapered. And again, everybody's an individual. So what about tapering prednisone? Well, I have to say there's not consensus. Clinicians use various tapering schedules, and in the pediatric community, the schedule in Europe, which typically was 3 days on, 4 days off, and lowering medication, and in the US and North America and other parts of the world is going to every other day, are quite different, and the rate of tapering is also quite different. In patients who have what I would call repeat relapses, it might be frequent relapses or relapses one every year or two, one finds over time that each person will tolerate a different tapering schedule. So again, the individual patient's important. But there can be quite a few symptoms with tapering prednisone: fatigue, bone and muscle aches, joint aches, mood swings, feeling cold, feeling hot, having a change in appetite, suddenly not wanting to eat at all after having had a ravenous appetite. One should be prepared that there may be changes. And if you're a parent of a child or you're the child, it's good to talk about this and make sure that you have a good line of communication in your family, among the family itself, and also someone to talk to in your nephrologist's office, or if your pediatrician manages relapses, it would be good to have a point person there. So what can you do? You can do gentle exercises, communication, and importantly, talk with teachers and others in the child's world. And if you're an adult, it can be worthwhile to tell people about it, especially if you have mood swings, people will more understand. The other thing is, if things aren't going well on a taper, changing the rate can be helpful. If, as a patient with nephrotic syndrome, there's a breakthrough and relapse while tapering, the rate of tapering has to change, and it may be that high-dose prednisone would be needed for a while. So what is new, finally? Well, there are a host of studies of other medications that have been done. They have rarely been done just comparing them to prednisone alone, but look at sources and you can see what's ongoing or coming up by looking at registries such as clinicaltrials.gov. If you go to that website, you can plug in nephrotic syndrome and see what active studies are and see whether they're in your area. Talk to your clinicians and say, I want to know what's new. And be involved in your own or your child's care. So that concludes what I was going to say to you. And now I would be very happy to take questions, and I'll stop screen sharing. And thank you so much for listening.
Thank you, Dr. Ingelfinger. We do have some questions coming in. So I'm just gonna start here. Someone has asked, after tapering off of prednisone, how long does it take to get out of your system? I was on prednisone for 8 years and have been off of it for 2 months, but I still feel and experience side effects from the prednisone.
Some of the side effects will go away fairly quickly, as you've probably seen. Most people within 3 months really start losing weight and start having a redistribution back to pre-prednisone configuration of body fat. But some things may really be permanent. Bone changes, if they have occurred with osteopenia, meaning not as much bone mineral density as other people, or frank osteoporosis, may require treatment to go away. Other things, such as susceptibility to infection, probably are really much less by 3 or 4 months. And other things, such as mood changes, may still persist for quite a long time, especially as tapering off something, if you've been on it for years, is not that easy. And one thing I would suggest to whomever asked this question is, in the second edition of the book, I was able to interview somebody who was very generous with her time, and there's a chapter about what if it's forever. This friend has been on various doses of glucocorticoids for more than 20 years at this point, and has coped with a lot of side effects. And one of the long-term ones has been some bone changes that have stayed with her. So there's a lot we don't know. And so that's a partial answer, and I'll be quiet because I see more questions.
Kristen, can I ask a follow-up question? This is Kelly. Hi,
Yes.
Dr. Ingelfinger. I want to ask a follow-up question that might help this patient. At what point do you suggest patients who are coming off of long-term high-dose steroid use see an endocrinologist to address adrenal fatigue and possibly adrenal insufficiency?
Thank you for asking that. I should have brought this up, and I don't think I said much about it in my part of the doctor voice in the book, Coping with Prednisone. I think somebody who has been on high-dose prednisone or other glucocorticoids for a long time should see an endocrinologist, both for bone change management and also to consider whether testing adrenal reserve is worthwhile. That can be tested, and nephrologists can test it, but usually endocrinologists do. And that's done by administering a test dose of ACTH and looking at what your adrenals can do. Because some people really have adrenal insufficiency and may have it for a long time. So thank you, Kelly.
Yeah, that is definitely a common question that we get around adrenal fatigue. So thank you for that. I have another question here from Gene. He says, your book strongly recommends not to use melatonin when on prednisone. My doctor said it may not be a problem at my level of prednisone, and if melatonin is limited to 5 milligrams per day. I have been using melatonin for about 4 weeks now, and it has been a big help with the side effect of insomnia. Do you have any thoughts or concerns about this?
At the time that we wrote this book, and thank you for this question, some of the preparations of melatonin were less standardized than they now are, and there was a lot less experience using it with insomnia. So I think it's okay. I don't know that higher doses are a good idea, but if it's helping, I would frankly use it.
Thank you. Another question here from Ruth, and I'm gonna preface it with, in your talk, you mentioned cushingoid syndrome. Could you explain a little bit about what that means? And Ruth's question is asking how to deal with an extreme Cushing reaction.
Well, a cushingoid state is induced by medication that you take, mimics that which can occur naturally owing to either a hypothalamic tumor or a steroid-producing tumor in the adrenal. And what it does is when it is really a pattern that is seen, and that is weight gain, redistribution of where fat is stored in the body so that the face gets rounder. There can be some fat on the top of the back around the bottom of the neck, and there can be weight gain in your middle, so that a large amount of tummy fat and thin arms and legs, along with other effects of prednisone and related medications like stretch marks, thinning skin, there can be glucose intolerance. In other words, many of the side effects I went through. So that the skin effects and fat distribution effects are sometimes so pronounced that you can see somebody, walking down the street and say, I think that person is probably on prednisone, if you happen to know the side effects. And as an adult, I can remember some people I knew in high school and college who were clearly back then on less good versions of these medications, but their body shape changed and I didn't know why. But once I knew what prednisone does, I can say, I really think that Esmeralda was on prednisone. So that's what is meant by it. An extreme case is part of this question, and that is someone with multiple side effects. And I think when that occurs, you need to talk to your clinician and also think about what you yourself are doing. And with that, what you need to do is say, I really have a lot of side effects. Can my dose be tapered? What can I do? If any of it is controllable by you yourself, have you been so ravenous that you've been eating all kinds of junk food? Would there be a way that you could change your diet and do some low impact exercise that would help? By the time this level of Cushing's syndrome has occurred from medication, reversing it quickly is often not as easy as one would wish.
Yes, difficult condition for sure. Catherine is asking, could you please expand on the reason of, you mentioned a medication that's not used in the United States,
Deflazacort.
Thank you. And expand on the reason why this medication has not taken hold in treatment protocols here, despite the research showing that it mitigates some side effects.
The quick answer is I don't know, and I haven't been able to get it to study it. And patients I know have tried to get it, and it's hard. I would be glad to see if I can find out something that is more than a sort of half-baked answer and give it to Kristen to post on NephCure. My guess, and this is just a total guess, is it's expensive to produce and perhaps the medication itself is not stable. And when that is the case, is it effective at all? And that's the usual reason. There's something with the medication itself. I have not read that there's a horrible adverse event that nobody's told us about. Sometimes things are hard to get or not approved in, say by the RFDA because there's a hint that there's very adverse cardiac events, for an example.
Yes, yes, absolutely. Dawn has a question, and Dawn's question reminds me about sections of your book where Eugenia spoke about one of the most hardest parts of her treatment was dealing with some panic, where she even had panic severe enough that it was affecting her ability to do her job, in which she had a very public job working for the CBS Sunday Morning. And so Dawn's question is similar. She says, as an adult minimal change disease patient, she has suffered severe mental issues with prednisone, and she's never had issues like this prior. Prednisone made me very paranoid and had a significant impact on my mental ability to remember things, execute her job properly. And do you have any suggestions on how to combat or cope with this portion?
I think that's not an easy question, but I have some suggestions.
Yes.
One is that it can be helpful to seek counseling or even get anti-anxiety drugs with a practitioner, see a psychiatrist or a psychopharmacologist, because most of them in almost 2021 pretty soon have seen patients with this problem. The other thing is to learn some behavioral techniques like cognitive behavioral therapy that allows you to say, I know this is my prednisone, it isn't me, this is going to pass. But again, that doesn't really help when something you have to do feels like you're climbing up Mount Everest and you've just lost your foothold. So I don't have a panacea for that, but it can be also very helpful to talk to coworkers, friends, and family, no doubt, knows, because they will usually be very understanding.
Yes, and Dawn—
Not a panacea, Dawn.
No, but and Dawn, I do have to say, I think sometimes just hearing that your symptoms are not unique is also helpful. And I do have to say, I know my book is, backwards, but, and you see, I have read this and paged so many things, but in the book, Dr. Ingelfinger's sister, Eugenia, does talk about these struggles and does talk about some of the things that she did to help her. So you may, if you have not read the book, I would encourage you to do so. I think that you might find some of it very enlightening. Another question here from Cynthia. What is your opinion on taking rituximab infusions to prevent minimal change disease relapse?
I think when one looks at the data, of rituximab, there are a number of things to consider. Taking it preventively, say you've had one episode or two episodes, seems to me risk outweighing benefit by far. Rituximab acts on B cells, which are kind of lymphocyte that fight inflammation and infection and are active in nephrotic syndrome, but it profoundly depresses them. And one of the long-term worries with rituximab is being oncogenic, leading to malignancy, which with many medications is there, but with Rituxan or rituximab, its generic name, is present. Furthermore, at least when I have reviewed periodically the data on rituximab and preventing long-term relapse, the number of patients studied is small, and the duration of the remission is disappointing. So I can say I would really think very hard about doing that, and I would never do it preemptively, if you will.
Thank you. Another question here from Yu Taiwan. He is referring to the conversation around deep vein thrombosis. He's wondering how common or how often DVTs may happen while on prednisone. And maybe if you would like to review maybe some of the symptoms that patients might look for, right?
It's rare. It does occur, so I felt bound to mention it. The frequency is maybe for someone who isn't a frequent relapsing person, less than 1 in 100. I would say in my life as a nephrologist so far, and as you can see looking at me, I'm not an ingenue. I have seen, I guess, 3 people with this problem. Of course, I'm seeing children and adolescents. All of them were adolescents. It may be somewhat more frequent in adults, but here are the symptoms of deep vein thrombosis to think about. One is, most often, these can occur in the calf muscles, and it's calf pain. And then when you feel your calf, you might feel what seems like a cord or a piece of wire in there that also usually is quite tender. There also can be swelling of your affected leg. There can be thromboses in the pelvic veins, in which case there can be swelling of your legs. But those are the main things. There's not usually fever. And if you ask about other clotting problems, the symptoms of a pulmonary embolus don't generally occur before one gets one, but the source is usually a deep vein thrombosis. So looking for those symptoms that I mentioned are worthwhile, especially if one developed swelling of one leg and not the other.
Thank you for that. Gina is asking, she has a 3-year-old son that was diagnosed with nephrotic syndrome in December of 2019, so a fairly new patient. And he is steroid dependent. She said they are switching to a second-line medication in the next few weeks since he has been unsuccessful at tapering for the past year. And at this point, considering his age being 3, what are some of the effects they should be aware of for his health and development? And would you have any specific health concerns?
Well, if your question, Gina, is generically another medication, the kind of other medications that are used are quite variable. I think that if you were asking, maybe you can clarify, were you asking about the other medications or long-term effects of prednisone?
Yeah, she's probably referring to maybe some long-term effects of maybe even, just, yeah, the medications. I think, in my opinion, as a nurse and working with NephCure, I think one of the biggest things that we really stress to our patients is the prevention, or the slowing any progression of obviously glomerular disease. And the whole point is to really stop the protein from spilling, right? To save kidney function. But she might be talking about, something more specific. I don't have a follow-up question from her.
So I would say, I'll try to be quick because I see more and more questions. In terms of starting a second-line medication, that almost certainly means continuing the prednisone while that comes on board, because that is virtually always necessary. And it would need to be tapered anyway, so I imagine maybe cyclosporin will be started, and with that, the prednisone tapered, or Cytoxan, or some people would use rituximab, or, there's a whole bunch. I'm not going to go through the list. But in terms of the prednisone, the long-term issues are, will it affect height growth? And probably at this juncture, not very much. He's been on it for 11 months, would be my understanding by the arithmetic of the number of months gone by. Will there be cardiovascular long-term problems? Hard to be sure. Does he have any evidence of cataracts? Probably not at this point. So that the long-term effects are probably not going to be maximal in terms of, or even much. My sense is, in terms of second medications, what you need to do, since there's no way, unless we met for an hour, I could go through the whole list, find out what their adverse events are, what the risk-benefit ratio is, and go from there. And one thing I should say that is worthwhile, and I think that it would make sense to consider a second agent at this point for your child, but this is for everybody. I do think that when things aren't going well, a good thing to do is, if you're worried, is this the only way, what else is out there? Getting a second opinion is something that we as doctors are fine with. If a doctor isn't fine with getting a second opinion, there is something wrong with that doctor, in my way. It's good to have input that's independent. It can help you as a patient, as a parent of a patient, to say, yes, I'm doing the best I can given this situation. So I think that is fine to do.
I think that is a wonderful way to end this webinar. We do have several other questions, and I will try to get answers to these questions for those of you who have not been able to get your question answered. I do appreciate everyone for being here. Dr. Ingelfinger, thank you so much for being here. Please express our thanks to your sister as well for,
I will.
Yes, because this book, as though it is a little old, it is still relevant and very valid today. If you have not gotten this book, I would encourage you to look at getting one for yourself. I find that this book is incredibly helpful. You can see all of my page notes in the book as well. Thank you for being here today, and I appreciate everyone. Have a wonderful Monday and a wonderful week. Thank you
all
so much
for listening. Bye.
Thank you.